Ladies and gentlemen, good afternoon. My thanks to the organizers for inviting me to give this presentation this afternoon. Back to real life now, and we're going to discuss communication between carers. Of course, no conflict of interest on the matter. The outline to my talk is as follows. What communication in the units, what communications both for the caregivers and the patients, and can we improve things? So we work in a unit that is very specific. We're a pluridisciplinary team. Often there are many of us in a highly technical setting taking difficult, challenging end-of-life decisions. And as we saw this morning in the keynote addresses, families and relatives suffer with the mortality rate of the order of 20%. The team requires a leader, a medical and paramedic leader, and I'll stress this point throughout my talk. Team, a collection of individuals who are interdependent in their tasks, but who share responsibility for outcomes. And in the hospital, we are a small unit within a broader unit, which is the hospital, and so there have to be relationship, interaction with the rest of the hospital. And so teamwork is first and foremost all about leadership, so that decisions are taken and that those decisions are communicated to the rest of the team so as to have coordination of behavior and also a common mindset, common processes that will be taught to the newcomers to build team spirit and focus on safety, and all this providing patient care. You may have seen here in this article in this magazine where there are a lot of accidents linked to a lack of communication, so the health authority is rolling out a program around teamwork. And teamwork isn't always optimal or optimized. Nurses tend to consider that they communicate well. Physicians with nurses, female nurses always communicate well, but nurses with physicians don't share this viewpoint, don't always feel that communication with physicians is optimal, as you know. And at the end of the day, it's very difficult for nurses to speak freely and for what they have to say to be heard by the rest of the team members. And this will lead to a perception of the appropriateness of care for the patients, not always viewed as the most appropriate care, both for the physicians and for the nurses, because in this study, respectively, 27% of physicians, 15% of nurses feel that the care is inappropriate, disproportionate, so far too much care for the patient. And to explain these results of this perceived inappropriateness of care, what promotes this perceived inappropriateness is when the physician is solely taking the decision when the nurse has a very high workload. But when there's good collaboration between the nurse and the physician, then we're protected from this perception of inappropriate care for the patient. And so these difficulties are crystallized in end-of-life decisions, because this study's shown that perception between by patients and nursing staff is different in the end-of-life decisions taken, cooperation between physicians and nurses in this multidisciplinary discussion, and taking into account nurses' input. So are there consequences stemming from these communication difficulties within teams? Of course there are consequences, and first and foremost, conflict between teams, discrepant views views or divergent views in this end-of-life study, we see that 78% of these decisions involve conflicts, and these conflicts on 50% of the decisions, almost 48% conflicts between staff members. Now, you're familiar with this study. This is an international study, 7,000 participants, 70% report a conflict. First and foremost of the explanation for these conflicts, we have communication problem, communication deficit between team members. Conflict, opposition between persons, always emotionally charged, but there's conflict in conflict. A team that doesn't have a conflict is a team that's just chugging along, no discussion possible. When there's too much conflict there's a risk of breakup of the team, so you have to strike a balance. The conflict has to be creative, must also promote change. Since conflicts are almost inevitable in teams, let's try and make them useful, that is win-win conflicts, preserving relations between carers and with positive results and outcomes after decisions taken. Otherwise, if we let the conflict establish, that will lead to stress, work satisfaction not good. Studies show that 40%, be they physicians or nurses, who want to leave ICU, and if we leave that stress take root, we'll arrive at burnout. And to achieve burnout, you need to have 1 to 5 years of chronic stress of teams. And when we look at the percentage of burnout in these teams, here I've given you both French studies, the studies conducted in Switzerland, where between 30 and 40%, be it for physicians or nursing staff. Burnout is very detailed in its symptoms over several years. Diagnosis is very difficult, and even with measurement scales, it's sometimes difficult to perform a diagnosis. There are other ways of performing the diagnosis, and that's why we have studies with burnout levels well below what was published previously. There isn't just burnout. This Famirea study shows that conflict is associated with depression. It's not, say, depression symptom because it was measured with scales. We have to distinguish between what's measured with a scale and depression that requires a clinical diagnosis. All this to say that these conflicts will lead to suffering experienced by the caregiver at work, and this professional suffering will be linked to subpar safety. These are residents, 20% conflict in the team. There are sources of conflict declared by the residents, iatrogenic events, without consequence and with consequence in grey. We looked at this very recently in the SRLF study. 31 ICUs in France, 1,500 workers responded. We have symptoms of about 17% professional burnout, with two different definitions which account for the two very different rates between these two definitions. When we looked at whether there was a link between suffering at work and the iatrogenic events with or without consequence, percentage of staff with burnout, whatever the significance in the various units, median 2.6% or 38.6%. There was no link with medical errors with and without consequences, but over 15% of staff in a team suffering from depression, there's a link with medical errors. and this result is to be found in other studies. Here in pediatrics, these are junior doctors. Rates of medication errors of the burnout are not linked to medication errors, but depression, yes. So this burnout at work will, of course, have a consequence on patient management. So can we improve things in this SRLF study? When we look at the various areas of the safety culture, we see immediately that, be it the nursing assistants or physicians, there's a perception with the long-term or short-term vision of the unit, how the unit is organized and how it's communicated to the various teams. Indeed, leadership, team leadership is crucially important in order to improve communication so that everyone feels good at work. This leadership will organize the work, put the right people in the right positions, define tasks and roles, and will organize the team. It's all about listening before communicating. Listen to your team and its needs to support and drive them in difficult times. And there are difficult times in the ICU when everything goes well. You have to delegate, key delegation of tasks, because it builds motivation. It values staff to be creative with a dynamic team and to be always present in the event of acute crisis. And these are key enablers to build a team and team spirit. And this leadership isn't only internal for the unit, it's responsible for the unit atmosphere. Before the management team of the unit, before it's understood, it must understand its teams, it must be open-minded to everything and lead neutrally and objectively. But leadership must be also external for the hospital and community to build the legitimacy of our unit within the hospital. We're not an isolated unit, we're interconnected with the other units, and we must be recognized by our learned society. And then human skills. Sometimes we don't always have those fully. We have to have what's known as an emotional bank account, understand the needs of our team members and accept differences of view, contradictions and criticism. There are reviews that have shown that there are interventions to improve team effectiveness and communication. Here there are 3 types of intervention. First of all, teamwork, training programs to promote systematic progress to master and improve team competencies. There are structured communication protocols based on checklists, and in order to improve patient safety and communication for patient management, there are care pathways for certain conditions. This review says about the same thing here. That is, standardized protocols, daily checklists, organize daily rounds, and simulation training. Let's look at this recent study which considers the implementation of a handoff program focusing on the rate of medical errors and adverse events. There are 5 points here. Firstly, handoff in terms of description of illness severity, patient summary, action items, situation awareness and contingency plans, and that it's all synthesized by the receiver. We see that before rolling out and implementing the handoff program in dark blue, we retrieve a lot of information with this handoff program. And the endpoint of the study, that is overall medical errors. After the implementation of a handoff program, there are fewer medical errors and avoidable adverse events, and near misses and non-harmful medical errors. If you consider the Swiss cheese diagram, where every slice of Swiss cheese is a near miss, and you have a medical error where all the holes in the Swiss cheese go in the same direction, and that promotes a medical error. When we reduce these near misses, there's a direct impact on the overall medical errors. We look at the medical error avoids errors related to diagnosis, errors related to therapy and to the history and physical examination of the patient, everything that's key to perform the right diagnosis. But in this study, medication-related errors were not significantly different. Let's now consider the use of a daily goals checklist made in Canada for the morning ICU round. A nurse, a pharmacist, a dietitian, a respiratory therapist, ICU fellow, intensivist, resident, student. It's a very robust team supporting the patient. They've introduced checklists to consider the use of this checklist over the morning round by performing a joint qualitative and quantitative analysis. Observation of the 80 morning rounds, in 80% the checklist was used. To give you an idea of the checklist, this is what it looks like. It's not very legible. So the nurse, we're looking here both at comfort, sedation, central lines, ventilation, nutrition, medication, everything that makes up the treatment of a patient at the bedside. So it's the previous day's nurse that updates the checklist. The next morning it's updated once again during the morning round with nighttime events, and it's completed by the resident. They looked at three main themes: impact on communication, care. Impact on communication, the checklist have led to a systematic approach of the patient. Here it is, we're far more systematic and organized, and we look very carefully at each area and check all the boxes, and it promotes multidisciplinary discussions, not just the physician who does his round, but there's real interaction between the various members in light of the items on the checklist. And it's a centralized repository of the patient's status and his plan that can be used if you haven't had time to take part in the morning round. So in these morning rounds there are recommendations, pretty compelling, powerful recommendations. In order to improve communication, it must have a physician, a medical doctor, and a nurse. Here they say, and a pharmacist, because we're in the US, but it needs to be at least two, and not just perform the round with the physician without the nurse. The visit must be organized. It's not just when the physician decides to do his round that it can begin. Otherwise, we can't always take part in the visit. If there are several members, each must play a specific role in order to interact, discuss, and provide an input in order to assess the overall state of the patient. We can use checklists. This is a strong recommendation, and minimize unnecessary interruptions during the process. There are other ways of improving communication. It's the care pathways. I know that in ICU the care pathway may not be of much interest, but there are conditions such as COPD where we can enter these care pathways. This is a study conducted in Belgium, randomized cluster, one arm that uses the care pathway, another that doesn't use it. The care pathways were evidence-based interventions developed in the centers with care pathways, and the caregivers who were surveyed in each arm showed that these care pathways had improved management support, reduced conflict, and increased leadership structure by reducing burnout. That's to say, to have the right people in the right place, and with those people knowing exactly what they have to do in terms of patient management, communication is thereby improved, and at the end of the day, patient care is improved. Just a couple of slides to show you this rather amusing study. It's the use of wireless email to improve healthcare team communication. Of course, it doesn't improve verbal communication. This is a plus. It's in Canada, in an ICU that's quite extensive, with two nursing stations, two geographic areas separated 150 meters, a lot of staff members. They just included daily shifts. A BlackBerry that supplied the phone plays obviously no role in the funding of the study here. I wanted to state that. And the carers who were assessed described whether or not they were satisfied with the emails they received. That is, instead of being interrupted in the tasks at the bedside of the patient by somebody who comes to say to you orally, well, infusion of room number 3 of the patient in that room needs to be replaced in 1 hour, and you have to do 2 things at the same time. Here they've solved a problem. That is, a carer sending an email to another caregiver, receiving on average 5 emails per day. Not very considerable, but it did allow them not to interrupt the task when the phone was vibrating in their pocket. This scale between 0 and 7. 7 very satisfied, 1 not at all satisfied. The average is a 4. Well, overall, as you can see, they tend to be pretty satisfied regarding the speed of communication, the impact on communication, on satisfaction, and on safety and the quality of patient care delivered. So, in conclusion, I would say that it's crucially important to improve communication in our units, because it impacts both on teamwork, on satisfaction at work, on patient management and safety, and of course reduced suffering at work and burnout prevention. Thank you for your attention. Ladies and gentlemen, good afternoon. My thanks to the organizers for